On this bonus episode of PodcastRx, Deborah Milito, Diamond's Director of Clinical and Consultant Services for the Long-Term Care Division, joins me for a quick and concise conversation about psychotropic stewardship. Deborah explains the CMS regulatory reasons behind her recent focus in this area, what psychotropic medications are of interest to CMS surveyors, and what ideal psychotropic stewardship looks like in the long-term care setting. We also talk about the strategies that Diamond consultant pharmacists use to promote effective psychotropic stewardship for client facilities. I'm Adam Campbell. Thanks again for listening to PodcastRx. Dr. Deborah Milito, Director of Clinical and Consultant Services, Chief Antibiotic Stewardship Officer, ASCP President-elect, golf enthusiast. Is there anything I'm missing? It's so good to have you back on PodcastRx. How's life been treating you lately?
Good, Adam. And something we need to add is I'm learning how to play pickleball.
Oh, learning how to play pickleball. That's awesome. Yeah, I hear so much about it. The growing sport. It's been around a long time, surprisingly, but yeah, it's all the rage lately. How's your game?
I am now an advanced beginner. I think the beauty of the sport is that people of all ages can play with one another. And I've played with guys twice the size of me, and I'm not very tall, and held my own. So
awesome.
There's that.
Awesome. That's fantastic. Well, good luck out there on the pickleball court, and one thing among many that you have going on. You know, Deborah, we've talked so much in the past about antibiotic stewardship, your work with that in the long-term care setting, and you've been such a visible audible advocate for antibiotic stewardship in the past half decade or so. And of course, that wasn't obvious from your job title. But lately, your focus is turning toward psychotropic medication stewardship. And I wanted to have you on to get a better understanding of this issue, why it's so important, both institutionally and for you personally. And I understand that psychotropic is a broad category of medication. So before we get into our full discussion, can you give me the most precise clinical definition of what psychotropic meds are?
Yes. So, Adam, why I've sort of switched gears for right now is that on October 24th of 2022, the Centers for Medicare and Medicaid Services, or CMS, released guidelines for surveyors. And they had a lot to do with psychotropic meds, such as hypnotics, antipsychotics, anxiolytics, antidepressants. And these are all areas that, as senior care consultant pharmacists, we look at every month. We even would look at on an admission drug regimen review. And so these guidelines that came out really are geared towards the surveyors to be looking for certain things. So I think it's items that we've already been doing as the consultant pharmacist, but now the surveyors are getting more educated as to what they should be looking at a long-term care facility.
And for the purposes, again, of our discussion, then which of the psychotropic medications are you looking at most in your everyday work and the surveyors?
So I think the one that's taking precedence right now would be the antipsychotics. There are some significant surveyor guidance as it relates to antipsychotics. So we have first and second generation antipsychotics, and the second generation pretty much are the atypical antipsychotics like Seroquel or Guaitiapine, Zyprexa, or olanzapine. Some of the first generations would be like haloperidol or Haldol.
You just talked about the regulatory framework of it, the CMS, in October. But what are some of the other factors that brought this to the fore for you and sharpened your focus in this area?
So as it turns out, there were some findings of some facilities that were giving the diagnoses of schizophrenia to residents that maybe should not have had that diagnosis. Mm-hmm. And the reason that happened was because there are 3 diagnoses that are not counted towards your quality measures. They are schizophrenia, Tourette's, and Huntington's. So, of course, we don't have that many residents with Tourette's or Huntington's, not too many with Tourette's at all, but a few for Huntington's. And so if someone had the diagnosis of schizophrenia, then that resident's antipsychotic use would not be utilized towards the quality measure for either a short-term or a long-term percentage, and therefore wouldn't affect the star rating of a facility. So the problem with that is that some residents didn't deserve to have that diagnosis. Mm-hmm. And quite frankly, schizophrenia is typically diagnosed in the younger age, from about 18 to 40. So for instance, a 75-year-old being, having that diagnosis attached to them would be very unusual. And so that was CMS was starting to see that there was an increase in the amount of residents being diagnosed with schizophrenia.
I see. So this is part of a larger problem of overprescribing and just trying to cut back on that.
Well, yes. And the other thing that was seen by CMS is that maybe they took somebody off of an antipsychotic, but they added like a mood stabilizing medication, such as Devalproex, which is Depakote. And Depakote is typically used for seizure control. So if someone were on an antipsychotic like Zyprexa for psychosis, and that was DC'd or discontinued, and they were then put on Devalproex for mood stabilization, but there was no mood stabilization type of, no mood disorder type of diagnoses, then you'd have to wonder, were they substituting one med for another to improve their star ratings?
So with all this in mind, then what is an appropriate psychotropic stewardship program look like? What are your ultimate goals when you're trying to set that up?
So as we've always done as senior care consultant pharmacists, is we ask for gradual dose reductions on a periodic basis. This is nothing that has changed for us, but I think surveyors will look closer at it than they have before, because they do mention gradual dose reduction of all psychotropics in the CMS guidelines that were published October 24th of 2022. So on our end, nothing, I don't think will change that drastically. There's probably some facilities that have consultants that maybe aren't as astute at doing that. But I know for Diamond, we've always done that on a very regular basis. In addition to that, we attend behavioral health meetings whenever requested. And I think that brings a lot of value to taking the best care that we can of our residents.
Can you talk some more about those specific strategies that you and the consultants take with the providers to improve the psychotropic stewardship?
So we like to talk about it as a team with the provider, the nursing staff, the social workers, the activities, dietitians. We like to all be present, whether it be a virtual meeting or in person, and we just take each resident and, CMS is all about the patient-centered care plan. So we are very specific in looking at, non-pharmacological attempts before a med is given, specifically if it's a as needed or PRN med, such as a Zyprexa PRN or a Seroquel PRN or even a Haldol, which, sometimes is used for a short period of time. We would be looking at, are there non-pharmacological approaches attempted before that PRN is given? And most importantly, we're looking to see that there's a 14-day cut on any PRN psychotropic medication.
And what are some of those non-pharmacological steps that can be taken?
So again, I think it used to be that you do a back rub or take a walk, something pretty vague, but we need to be more specific for each resident. So maybe something like a cup of hot cocoa or a People magazine or, calling a daughter to speak to them. Anything that would have a calming effect on the resident, whether the resident can say what that would be or their loved one can speak for them and say, this is what worked at home to kind of calm mom down.
Yeah, rather than just, here's a medication, walk away.
Right.
And I was curious, Deborah, what do patients, providers, maybe even sometimes pharmacists misunderstand about psychotropic medications? How does this contribute to any mistakes made in prescribing them or using them?
So there are approved indications for the psychotropic meds. Like, for instance, the antipsychotics. They're approved for psychosis, for bipolar disorder, and for the other diagnoses that I talked about a little bit earlier. And I know at the national level for the American Society of Consultant Pharmacists, or ASCP, of which I'm president-elect, we are working on a project called Project PAUSE, PAUSE. And this is where we're asking CMS to please consider reevaluating the exemptions to the diagnoses for antipsychotics, because there are approved indications other than schizophrenia, Huntington's, and Tourette's. And quite frankly, there are residents that have bipolar disorder, for example, that absolutely need to be on that antipsychotic. And so that's counting against the facility because it's not on the list of exemptions. So we are working with CMS to please review their list of exemptions that has not been reviewed for 10 years.
Yeah, 10 years sounds like it's due.
I think it's time.
Yeah. How have the facilities that you work with responded to your overall psychotropic stewardship measures?
They really appreciate our involvement in the behavioral health team. They like any in-services that we can provide on what does a gradual dose reduction look like, what are some approved indications, or we're looking at every PRN psychotropic to make sure it has a 14-day discontinuation. So the more we can provide to the staff, the better. And we try to talk to every member of the nursing department so that they all have a very clear understanding of where we're coming from. And then we'll talk with the medical directors, any physician extenders such as nurse practitioners and physician's assistants as well.
You know, as we said at the top of the show, antibiotic stewardship is such a defining issue for you. Going forward, Dr. Milito, how prominent will psychotropic stewardship be in your clinical repertoire?
Well, when the October 24th guidelines were released, we thought, okay, we can work with this. And before we knew it, on January 18th of 2023, CMS upped their game and said, we're going to start to do off-site audits of your antipsychotics. So they're not even coming into the facilities. They are contacting them, and they are getting lists of residents, and they're looking to see anybody that has a schizophrenia diagnosis, if there's good documentation in the chart from a while back that why they were diagnosed with that. So if they find any irregularities, there could be a decrease in the star rating of that facility, and there could be monetary penalties as well.
So that's just, again, underscores the importance of what you all do as consultant pharmacists to keep everyone within the regulations and ultimately keep the residents healthy.
That's the bottom line.
Yeah. Well, Deborah, I want to thank you for stopping by to talk with me about this very important issue, and we'll talk again soon on another host of regulatory issues that we discussed before getting into this one. We'll talk again very shortly. So thank you again.
Thank you, Adam.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.